Okay, so this is where we left off last time. So we're going to start to talk about myocardial delayed enhancement. So what happens to the myocardium when we administer gadolinium and do MR imaging? Well, normal myocardium will take up the gadolinium quickly, and then it washes out rather rapidly. What happens if you have infarcted or injured myocardium is that the uptake of gadolinium is delayed, but the washout of gadolinium is also delayed. So when you're out here about 10 minutes after you've given the contrast, there's more gadolinium within infarcted or injured myocardium or pathologic myocardium than there is in normal myocardium. So if you do a T1 weighted sequence out here, where we see myocardial enhancement then usually indicates abnormal myocardium. So gadolinium accumulates and clears slower in injured myocardium compared to normal myocardium, and that means that we will have higher signal on delayed imaging on T1 weighted scans. So here's an example, somebody with infarction over here on this short axis view, okay? So what we have here is 2 minutes after we give gadolinium, we can see a little bit of enhancement. 6 minutes, there's a little bit more, but once we get out to 10 minutes, now you can really see that contrast here between the abnormal myocardium where there is an infarction compared to the normal myocardium. So about 10 minutes out is when you have that maximum difference in enhancement between abnormal and normal myocardium. So in the setting of a myocardial infarction, myocardial delayed enhancement is associated with non-viable myocardium, usually indicates dead myocardium. But in addition to myocardial infarction, there are other things. Any cause of myocardial injury might give you myocardial enhancement, especially inflammatory conditions like myocarditis. And then what we need to do is try to differentiate those from myocardial infarction. So to do this sequence properly, what we want to do is we want to suppress the signal from the normal myocardium so that the normal myocardium is nice and dark, and that brings out that contrast between the normal myocardium and the abnormal myocardium. So to do that, to suppress the signal from the normal myocardium, we use an inversion recovery sequence. And we've talked about this before, where we have longitudinal magnetization. If we give a 180-degree inversion pulse, and then as this starts to recover, according to the T1 of the tissues, at some point it goes through we have the null point. And if we start imaging at the null point, if we can find the null point for normal myocardium and image at the null point of normal myocardium, then we can suppress the signal from the normal myocardium and bring out that difference between abnormal and normal myocardium. So this recovery rate of this longitudinal magnetization is related to the T1 of the tissues. So here we have an example here. So the red line indicates abnormal myocardium, either infarcted or injured myocardium. And then the green line here indicates normal myocardium. So as we've said, where we have abnormal myocardium, it will hold on to gadolinium. So that means it will have a shorter T1, which means that this longitudinal magnetization will recover faster. So what we want to do is to find the null point or image at the null point of normal myocardium here, and then as this longitudinal magnetization recovers, the abnormal myocardium will have more longitudinal magnetization. So if we start an imaging sequence, this will give us signal, and the normal myocardium will not give us signal. So if we can suppress the normal myocardium here by imaging at the null point, we will see an optimum difference in contrast between abnormal myocardium and normal myocardium. So this is how we use inversion recovery to do this late gadolinium enhancement or myocardial delayed enhancement pulse sequences looking for abnormal myocardium. Now, the one issue is that this null point may vary between patients. Is that in some patients it will be at lower inversion times, in some patients it will be at higher inversion times. And so what we want to do is we want to find the null point for the normal myocardium. So here's an example where our inversion time here is 200, and it wasn't correct to suppress the normal myocardium. So you see the normal myocardium here is rather bright. But if we use an inversion time of 250, now we're closer to the null point here, over here. So now we suppress the signal from the normal myocardium, and now it's nice and dark. So the trick is sometimes finding this optimal inversion time. We'll do it on one slice, find that inversion time, and then once we have found it, we will use that to image the entire heart. Usually we start out with short axis views. Usually that optimal inversion time is somewhere between 200 and 250 milliseconds. I mean, realistically, it can be anywhere between 160 and 250 milliseconds. Sometimes more, sometimes less, but 200 is a good place to start. So how do we do this? How do we find that optimal inversion time? Well, we do it by using what's called a look-locker sequence. So what we do is we take one slice location, one short axis view here, and we will image it as we change the inversion time, as we go through different inversion times. So what we're doing is we're using different inversion times along this curve until we happen to arrive at the right one that nulls the myocardium. And we will know that because the myocardium will turn dark. So as we go through this, we start with lower inversion times and going higher, and you can see how the myocardium at the lower inversion time starts out bright, and then it gets dark, so that's going to be your optimal inversion time, and then it starts to get brighter again, okay? So then that would be the inversion time that we would select to image the entire heart. So here are some examples. Here's an inversion time of 100. The myocardium is dark. Is still bright. It's not dark. Inversion time of 160 milliseconds. It's getting darker, but not quite there yet. Here in this patient, an inversion time of 270 seems to be just right. Now we get really nice suppressed myocardium. And then when we go greater than that, an inversion time of 330, the myocardium is getting brighter again. Okay. Also notice that the blood pool also changes here. You see how at the lower inversion time, the blood pool starts out as bright, and then it suppresses here. In this particular case, it suppresses at an inversion time of 160, and then it starts to get brighter again. Normally, the blood pool will suppress before the myocardium because you expect the blood pool to have more gadolinium within it. So the T1 time of the blood pool will be shorter. So shorter inversion times would suppress the blood pool before you suppress the myocardium. Now there is a condition where the myocardium might suppress before the blood pool as you go through this sequence, and that is this is one criteria that we might use to diagnose that condition. What is that condition? So what's the condition where the myocardium, well, who's studying for boards? Yeah, amyloidosis, absolutely. So in amyloidosis, the myocardium might actually suppress before the blood pool. So, well, that's one of the clues very early on that you might be dealing with a case of amyloidosis, okay? So once we have found that inversion time, once we found, okay, for this patient, 270 works really nice. Once we found that, based on our one slice location, now we will image the entire heart, usually from base to apex, in short axis views with this sequence. So we'll start there and do short axis views. And then I've shown you how once you have your short axis views, you can generate any of the other views that you want. So once we've obtained our short axis views, we then can get 4 chamber views. We can get 2 chamber views. We can get left ventricular outflow tract views. So you can do all of these off of your short axis views, and I've shown you how you can do that. So this is how we do myocardial delayed enhancement, looking for abnormal myocardium. Now, what I've just discussed is the way we do it when you have to find the optimal inversion time for the particular patient. There are newer pulse sequences called phase-sensitive inversion recovery. And so these pulse sequences then would allow you not to go through that whole tedious process of finding the optimal inversion time for the particular patient. So what I've described to you so far is kind of illustrated here. So here we have abnormal myocardium, right, where the gadolinium builds up. It has a shorter T1, it recovers faster. Here you have normal myocardium. And so what I've told you so far is we want to image at the inversion time right here. And when we image right there, you can see that the signal from this normal myocardium is nice and suppressed. It's dark, okay? But because the injured or infarcted myocardium has more gadolinium, you see here that's going to be brighter. Well, what happens if we image at an inversion time that is too low? Well, you see here that the way I've described it so far is that this viable myocardium, the normal myocardium, still shows up bright, okay? And your infarct or injured myocardium will also show up bright. Go across here to this bar. And so then we don't see the contrast between the two, which is why we try to find here the optimal inversion time to suppress the normal myocardium. With phase, and then the same thing happens if your inversion time is too long. If your inversion time is too long, now you have longitudinal magnetization here from your viable myocardium, which will give you signal, and then you don't get very good contrast between normal myocardium and abnormal myocardium. With this phase-sensitive inversion recovery sequences, these sequences can differentiate when the longitudinal magnetization is below the baseline as to when it is above the baseline, and then correct for that. So if we're using these newer sequences, these phase-sensitive inversion recovery sequences, it will keep the viable myocardium dark even if we happen to image below the optimal inversion time. It will still keep it dark, and the myocardium with more gadolinium in it will still come out brighter. So even if we happen to pick an inversion time down here, right? So with phase-corrected inversion recovery sequences here, the viable myocardium will still show up darker than the infarcted or abnormal myocardium, okay? So this can save you some time in terms of going through the whole process, finding the optimal inversion time. And so here's an example of that. So this is the way that I previously described, where we have to find the correct inversion time. So you see here for this patient, the infarct is over here along the inferior wall. Okay, here's the normal myocardium. We're at an inversion time of 300. This optimally suppresses the normal myocardium, and you can see the infarct very nicely enhancing against the normal myocardium. Here, if the inversion time is too low, the normal myocardium is actually bright, and it winds up suppressing the infarcted myocardium, right? So you don't want to be imaging down here. But if we use our phase-sensitive inversion recovery sequence, it keeps this myocardium, the abnormal myocardium, bright, and it keeps the normal myocardium dark. Okay, so that's the advantage of this sequence, is you don't have to find the perfect inversion time. As long as you're reasonably close, it will keep the normal myocardium dark, and it will show you the abnormal myocardium as brighter. The contrast still shows up best if the inversion time is close to the optimal inversion time. Okay, but this might save you some time, and you don't have to go through the process of actually finding the perfect inversion time. Okay. Now, myocardial delayed enhancement indicates abnormal myocardium. So if the myocardium is bright on your delayed enhancement sequences, it is abnormal. That can occur whether you have acute or chronic infarcts. All right? With an acute infarct, what happens is you have ruptured cell membrane, so the gadolinium will leak out into the interstitium. So the gadolinium will collect there and will appear bright. So even in acute infarct, it will show up bright. What happens with a chronic infarct is that the infarct converts to scar tissue. And scar tissue does enhance. Scar tissue accumulates gadolinium. So both acute infarcts and chronic infarcts, both of these will be bright on myocardial delayed enhancement sequences. So here's a patient, acute infarct 3 days after myocardial infarction. You can see the infarct here, kind of along the septum and anterior wall. And then 6 months after myocardial infarction, there's still myocardial delayed enhancement. It still enhances. So acutely, it's because the gadolinium is just leaking out into the interstitium because of the damaged cells. Chronically, it's because the myocardium, the scarring forms in that region, and scar does enhance. Okay? Now, it is important to be able to differentiate infarction as a cause of delayed enhancement versus non-ischemic causes of delayed enhancement. And one thing that helps is the pattern of the enhancement. So the two criteria that we look for to say that delayed enhancement is caused by an infarct is that it should always involve the endocardial surface. The endocardium is the most ischemic portion of the myocardium because the coronary arteries enter into the myocardium from the epicardial region, right? So they penetrate down from there. So the endocardium is the most ischemic portion of the myocardium. So an infarct, if there is delayed enhancement from an infarct, it should always involve the endocardium. The second criteria is that we want the enhancement to be along a vascular distribution, so along the territorial distribution of a coronary artery. So those are the two criteria that we look for to be able to say that a region of abnormal enhancement is caused by myocardial infarction, is caused by ischemia, as opposed to non-ischemic causes of myocardial delayed infarction, myocardial delayed enhancement. So here's an example of delayed enhancement, again from an infarct along the anterior wall. Sometimes with acute infarcts, there will be a region that does not enhance within the very core of the infarct. That is called, that phenomenon is called microvascular obstruction. What happens here is this is the most severe portion of the infarct. Here capillaries are thrombosed and the gadolinium can't really get in there. And so this region is not viable myocardium. This is severely injured myocardium. This does not enhance in an acute infarct. So if we see an island of darkness here within an area of enhancement and the rest of it looks like infarction, then we're dealing with microvascular obstruction in an acute infarct. So this is one way to differentiate acute from chronic infarcts. This phenomenon does not occur with a chronic infarct. With a chronic infarct, this entire area will convert to scar, so all of this will enhance. So this phenomenon of this dark area, an area that does not enhance within an infarct, means that you're dealing with an acute infarct, and this represents microvascular obstruction. Infarcts don't have to be full thickness. Even partial thickness infarcts can give you delayed enhancement. So here's an example of partial thickness infarct. Remember, the infarct should always involve endocardium and should be in a vascular distribution to be able to say that those are the criteria for us to be able to say that the abnormal enhancement is from infarction. But infarcts can be partial thickness. So here's another example of a partial thickness myocardial infarction here. Okay, so short axis view, and we see this infarct here. It's not going all the way through. It does involve the endocardium. And what vascular distribution is this in? Yeah, this is in the distribution of the distal RCA, the distal right coronary artery. So it does involve the endocardium. It is in a vascular distribution, so it fulfills our criteria for enhancement caused by ischemia or an infarct. And in this case, it's partial thickness. Okay? So it's a partial thickness myocardial infarction. Now we can combine early first pass imaging with delayed enhancement. So if we have an infarct on early first pass imaging as we're dynamically injecting the gadolinium, if we happen to image, there will be a perfusion defect where the infarct is because the uptake of gadolinium there will be delayed. But the washout of gadolinium will also be delayed where you have the infarct. So on your delayed, myocardial delayed enhancement images, you will see these areas of abnormal enhancement. Okay. All right, so let's move on to something else now. So here we have two different patients. These are both short axis views. So here's one patient, here's the second patient. So this is the abnormal patient. What is abnormal? First of all, what kind of sequence is this? Well, I've told you it's a short axis view, but what pulse sequence are we using here? Well, let's start with the easy part. Is it dark blood or bright blood? Yeah, so this is dark blood imaging, and you said it is what? Yeah, so this is double inversion recovery fast spin echo sequence. So that's what we usually use for dark blood imaging, all right? So when we compare the abnormal patient to the normal patient, does anybody notice anything that looks different? Yeah, so we notice, when we look at the myocardial signal here, you notice that the myocardial signal here is darker than in this case, right? Definitely darker. So what's the criteria? Well, the signal of the myocardium on these sequences should be about the same as the skeletal muscle, right? Should be close to skeletal muscle. This one looks darker. What else is darker on that image? What? The liver, yeah. So the liver, notice the liver here in the normal patient compared to the liver here in the abnormal patient, right? So the liver is also darker. What does this mean? Yeah, so there's iron deposition. So there's abnormal iron deposition here, not only in the liver, but also within the myocardium, okay? For those of you studying for the boards, if we want to quantify this, there is a pulse sequence that we use for quantifying the severity of myocardial iron deposition. What do we call that? Nobody's studying for boards yet. Okay, that's called T2 star weighted imaging. All right, so how does this work? Well, when there's iron is obviously ferromagnetic. When iron builds up within a tissue, it causes dephasing. What does dephasing cause? What's the implication of dephasing when you're dealing with signal? Yeah, it makes you lose signal. So dephasing causes you to lose signal. So as we look at a particular slice location here within the myocardium, if we look at it at a TE of 2 milliseconds, TE of 4 milliseconds, TE of 6 milliseconds, now you would expect the signal to decay, right? Because that's just what happens. The longer your TE is, it allows more time for dephasing, so the signal decays. But there is a rate at which that signal decays. So here in the normal patient, you can see that this looks a little bit darker than this, right? But the signal is decaying gradually, right? So the signal is decaying, but it's decaying slowly. As opposed to when you have iron deposition. When we have iron deposition within the tissue, this signal decays much more rapidly. So as we lengthen the TE and watch how the signal decays, you see here that it decays more rapidly. We can measure that and generate a T2 star curve to show you how rapidly the signal is decaying. And depending on certain criteria, then there's a criteria that we do use to decide if there's significant myocardial iron deposition based on the decay of this T2 star curve. What is that criteria? Does anybody know? The number? T2 star time constant of less than 20 milliseconds, but let's talk about that. So when there is iron deposition, the signal decays more rapidly. So you can see it's getting darker, but it's getting darker faster. So here's the normal patient. You can see how that signal decays. Here is the abnormal patient. You can see that this signal decays much more rapidly. So we can measure the time constant for this curve that gives us a T2 star, what's called a T2 star time constant. The magic number is 20 milliseconds. If it is less than 20 milliseconds, then that fulfills the criteria for significant myocardial iron overload. Okay? So here's an example again, TE of 2, 4, 6. Here's our normal patient. You can see that the signal really does not decay that much. Here's the abnormal patient. You can see it decays much faster. We measure that decay, come up with a T2 star time constant. And in this case, it was 7.5 milliseconds as opposed to the normal patient where the T2 star time constant was 48 milliseconds. So what we can do is, or what the clinicians can do is you take the patient who has iron overload, you treat them with chelating agents, and then bring the patient back for follow-up imaging. If your therapy is effective, what should happen? Yes, this number should go up. Okay, so this is a way that we can use MRI to quantify myocardial iron deposition, and we do this with T2 star weighted imaging. Okay, and you can also color code the myocardium based on the T2 star. I mean, the software can do this for you. We can measure the T2 star of all of the pixels in your image and then color code the image to show you where it is less than 20 milliseconds, so that's indicated as red over here. Okay, so you can do that if you want. Usually, since it's a diffuse abnormality, what we usually do is just measure one area in the interventricular septum, and we take an area of interest in the interventricular septum and we measure the T2 star time constant of that, and as long as it's greater than 20 milliseconds, then the patient does not have iron overload. Again, you can usually tell on your images too. You saw how the liver can look dark and the myocardium can look dark. So usually you have some clue, even before you do this, that there's something abnormal with the myocardial iron deposition. All right. Okay, so let's move on now. So the next thing we need to discuss is T1 mapping. So what is this all about? You can actually measure we talked about in our first lecture what the property of T1 is, right? That recovery of longitudinal magnetization. You can measure that. You can measure the T1 of the myocardium. You can do it anywhere. You can do it for the entire myocardium. So you can measure the T1 of the myocardium. You can do it before and after contrast. You can also measure the T2 if you want. Although for the most part, it is native T1 or the T1 of the myocardium before giving contrast that is usually clinically used or becoming clinically used to look for diffuse myocardial abnormalities. So you can do this with a look-locker sequence, like we talked about before, where we look to see, we generate this curve about how quickly does the signal recover once we give a 180-degree inversion pulse, and then from there we can generate a curve and then calculate a T1 time constant for the myocardium or for any region of interest based on how quickly the longitudinal magnetization recovers. So that is called T1 mapping. So why is this important? Well, your native non-contrast T1 times, so you can have abnormal T1 times, will be elevated if you have edema, fibrosis, amyloid. So one easy way to think about this is that you think of water and edema. What does that do to the T1 time? What does edema do to T1 time? Water has a short T1 or a long T1? What? Long T1, yes. So water has a long T1. So you think of pathology, usually pathology has a long T1 and a long T2, right? That's why pathology tends to be bright on T2 weighted images, okay? So if you remember that, you can remember that T1 times will be elevated in edema, fibrosis, and amyloid. There are conditions, though, where the T1 time will be decreased, okay? First, fat has a short T1, right? So fat has a short T1. So T1 times will be decreased if you have fatty infiltration, right? So we understand that. Iron also will shorten the T1 time. So you can do T2 star weighted imaging for iron deposition, or you can do T1 mapping for iron deposition. So it can show up here too as a shorter T1 time. Fabry's disease is a very rare disease where you have abnormal sphingolipid deposition in the myocardium. It's a storage disease, and because there is some lipid that is abnormally stored, that also can act as fat, and that can also decrease the T1 time. Usually the types of pathologies that we're going to be looking for, though, especially diffuse fibrosis from cardiomyopathies, usually it will cause elevation in the T1 times. These are the exceptions. Okay, so the T1 times, what we can do then is we can measure the T1 times of our native myocardium, and we can plot that, compare that to normal myocardium, and then we can find abnormalities within the myocardium. Here, there's this focal area of hypertrophic cardiomyopathy here. So when you measure that area over there, we can see that the T1 time there is prolonged. It takes longer for that to recover compared to more normal myocardium. Okay, so this is T1 mapping is another way to look for pathologic regions of the myocardium. So how does this help when you're dealing with the major application of this is usually with cardiomyopathies that cause diffuse fibrosis within the myocardium. If we have regional disease like a myocardial infarct, this is pretty easy to see with our conventional imaging sequences. Where you have focal disease, you will have delayed enhancement, right? So where you have an infarct, we can see the delayed enhancement. It's pretty easy to find, okay? So usually not a problem. But if you have non-ischemic cardiomyopathies, where you have diffuse fibrosis that is uniform throughout the myocardium, then the entire myocardium is abnormal. And when we do our inversion recovery sequences and do myocardial delayed enhancement sequences, looking for abnormal regions of enhancement, what happens is we just wind up suppressing the whole myocardium because all of the myocardium is the same and all of the myocardium is abnormal. So where there are diffuse abnormalities, it's hard to find those abnormalities when we do our conventional myocardial delayed enhancement sequences. And this is where T1 mapping can help. So where there is diffuse fibrosis in the myocardium, here the T1 times, the native T1 times of that myocardium will be abnormal, even though on myocardial delayed enhancement sequences, you won't find the abnormalities, okay? So this is where the T1 mapping can be helpful. So as I've said, where we have an infarct, it's usually pretty easy to find, on your delayed enhancement sequences, but where you have diffuse abnormalities like diffuse fibrosis, here, this will not show up as areas of abnormal enhancement on your myocardial delayed enhancement sequences. The only abnormality one abnormality though that you might find is abnormal T1 times, as the T1 times here within this abnormal myocardium will be abnormally elevated compared to normal patients. Okay? Now, the one problem with this is that there are many things when you're trying to measure the T1 time of myocardium, there are many things that can throw it off. You don't have to memorize this list, but just to illustrate, all of these things, right, can affect the T1 time that you're trying to measure. It's even harder if you're going to try to measure it after contrast. So that's why it's kind of, it's usually just looking at native T1 times before contrast, looking for abnormalities. But because there are many things that can affect it, the T1 times, your normal range of T1 times have to be standardized at your particular center. So on your magnet, on your machine, at your particular location, you have to scan a whole bunch of normal patients and then standardize what the normal T1 times are for your particular center on your particular machine. And it's after you've done that that you can start to apply this and then look for pathology. Okay, so that is one caveat about doing this, is it has to be standardized at your location after scanning a bunch of normal patients. Okay, so now the last thing we need to talk about here is this concept of extracellular volume fraction. So this is another way of looking for diffuse abnormalities within the myocardium. So what does this represent? It's the proportion of the extracellular space in the myocardium or the interstitium and the extracellular matrix. So it's this ratio of your extracellular myocardial volume relative to the cellular myocyte volume. So where there is diffuse fibrosis, this increases, this ratio goes up. So here where you have normal myocardium, you have lots of cellular myocardium, there isn't much extracellular stuff here, okay? But where you have fibrosis, where you have diffuse fibrosis, you can see now that there's collagen, there's more collagen out there in the extracellular matrix. So that ratio of stuff out there, the extracellular versus cellular, is higher where you have diffuse fibrosis. And so that's this extracellular volume fraction. So where you have diffuse fibrosis, if you can calculate, we're going to try to calculate this with MRI, is that this number, this goes up. And so it's an indication of diffuse fibrosis, of collagen in the extracellular space. So we do this also with gadolinium. So what happens with the normal myocardium is that we will have some gadolinium in the extracellular region. So after we give gadolinium, we'll have some gadolinium out there in the extracellular space. And then, of course, you're going to have gadolinium in the blood pool also. Here, where you have fibrotic myocardium, because there's more extracellular space here, there's more collagen out there that will uptake the gadolinium, now you're going to have this ratio of gadolinium out there, that extracellular gadolinium in the extracellular space, there's going to be more gadolinium out there compared to the normal myocardium. So if we compare that ratio of gadolinium out there compared to the gadolinium in the plasma, it's going to be greater here where we have fibrotic myocardium. So it's that ratio that we're looking at. What's the ratio of gadolinium out there versus the gadolinium here within the plasma? And that ratio goes up when you have fibrotic myocardium. And so we're going to use MRI to measure this. Bunch of equations. I'm going to show you a bunch of equations. You don't have to worry about the equations. It's the concept that's important here. So fibrotic myocardium has more gadolinium in the myocardial interstitium. That increases the extracellular volume fraction. So what this extracellular volume fraction represents is this ratio of the concentration of gadolinium out there, right, versus the gadolinium within the plasma. So we're going to measure, we're going to use MR to indirectly measure these concentrations of gadolinium. Also remember that, when we try to measure gadolinium here within the blood pool, this includes not just the plasma, but also red blood cells, right? Hematocrit, which is why to do this properly, you need to measure the hematocrit of the patient to correct for the hematocrit of the patient here, okay? So complicated equation. Don't worry about the equation itself, but this is why the hematocrit falls into this equation, because when we measure gadolinium, the amount of gadolinium out here, that includes both plasma and hematocrit, and you need to correct for the hematocrit. So that's why hematocrit winds up in the equation here. So we have to measure the concentration of gadolinium out there and the concentration of gadolinium there in the blood pool. Well, how do we measure the concentration of gadolinium, right? We're not going to actually sample this. We're not going to biopsy it and measure it. How do we measure the concentration of gadolinium with MRI? And it turns out there's this very interesting relationship, is that this concentration of gadolinium can be calculated based on differences in T1 times. Before you give, if you take the difference of T1 times, the inverse of the T1 times here using this equation, pre-contrast versus post-contrast, that the concentration of gadolinium is proportional to that difference. Concentration of gadolinium is proportional to the change, to the inverse of the change in T1 times. That's kind of an interesting how that works out, but it allows us then to do this. So this is the equation that's used. Again, you don't have to worry about the equation, but by calculating the T1 times out here and the difference in T1 times out here before and after contrast and the T1 times here in the blood pool before and after contrast, we can arrive at this extracellular volume fraction here calculation. Okay? So how is this done? This is what I want you to know. It requires measurement before and 15 minutes after you give gadolinium. You need to know the hematocrit for the patient to be able to correct for that. And in the setting of myocardial fibrosis, it can predict outcome as well as the ejection fraction predicts outcome. The extracellular volume fraction increases with pathology, with inflammation, edema, infiltration, and fibrosis. Don't worry about the normal value, but that is the normal value. Now, so theoretically, this can be very powerful. One of the drawbacks of this, though, is that it does require the hematocrit. And it requires a recent hematocrit. So ideally, it should be one that when the patient is there, right? It can't be taken 2 weeks before, especially in women who are menstruating, right? So that is one drawback of this method, is that it requires a very recent hematocrit to be accurate. And this is why I think clinically T1 mapping is somewhat more useful than this, because that doesn't require that extra information. Okay, so you can calculate native T1s, native T2s, ECV, but the native T1 seems to be the way most centers. This is what most centers use as now part of their protocols when they're doing cardiac MRI. So when we look at, what happens with pathology, what happens to the extracellular volume, what happens to native T1 values, remember I said that fat will decrease your native T1. So where you have fat, that will be low. Where you have iron, Fabry's disease, low. Where we have pathology like hypertrophic cardiomyopathy, myocarditis, myocardial infarction, that tends to increase in amyloidosis. This tends to increase your T1 times. And then all of these diffuse pathologies that we tend to look for here, like amyloidosis and fibrosis from chronic cardiomyopathies, from non-ischemic cardiomyopathies, these tend to increase your extracellular volume fraction and increase your native T1 values. And so you can look for these diffuse abnormalities by doing T1 mapping. So if we have myocardial fibrosis, what happens to the native T1 time? It goes up. What happens to the post-contrast T1 time? It goes down, right? Pathology usually holds on to gadolinium, which will shorten T1. And what happens to the ECV? It goes up. Right. Okay. And then you can generate these color-coded maps. This is how it's done, where these are color-coded for, there's the color, you can arrange the colors however you want, colors that are lower than normal, higher than normal, and normal. And then you can generate those color-coded maps. Okay? So native T1 time goes up, post-contrast T1 time goes down, ECV goes up. Okay? All right, so that is our discussion of this introductory to cardiac MR, and then we'll talk about pathologies as we get into them in future conferences. Any questions? Okay.